Are you able to see my slides? Okay, so I will take you through the Ethiopian perspective of care for children with disability and how COVID has impacted our care. So this is our hospital. It's the major tertiary hospital in the city. It's a university hospital, Tukur Ambassa Specialized Hospital. So as much as we need it, there are no developmental pediatricians in Ethiopia. And children with different kinds of disability are found dispersed among the different clinics in our hospital. So we see about an estimated about 850 children with disabilities each month in the different clinics. And our hospital is known to be overloaded with patients, and due to this high load of patients and more focus given to the associated impairments, children with disability have been consistently getting minimal care. So what we are basically focusing is on the disease condition of these children, while the activity, participation, and all the routine life of these children was unintentionally ignored. So we have identified huge intervention gap in our care for children with disability on a study done by me and my advisors on the pediatric neurology clinic. It was a prospective clinical cohort on children with cerebral palsy. We studied the clinical subtypes, the motor function, associated impairments, and the possible risk factors. So in our pediatric neurology clinic, we see 500 to 700 children each month. And among these children, about 30% are having cerebral palsy. So in this study, 174 children with confirmed diagnosis of CP were included. And we found out that the severest form of CP, which is spastic quadriplegic type, predominates, and 75% of the children, they are found on the severe impairment in both gross motor and fine motor function, and only 40% had milder levels of impairment. And we have found that almost all children, they had either one or more associated impairments, with speech difficulty being the predominant one, followed by intellectual disability and seizure. And the most interesting part is that we identified was there was no event during the antenatal period of these children. However, 2/3 of these children had neonatal admission right after delivery, 76% with respiratory distress, and another, the rest with infection. And during their first months of life, half of the children, they had infection, and another half, they had difficulty breathing, seizure, and trouble feeding. And notably, less than 10% were preterm and none were below 1,000 grams. So this shows the huge intervention gap that we are practicing during the perinatal period. And the other finding was there was a great discrepancy in diagnosing CP among clinicians. So in our study, we have found 22 children who were previously diagnosed as CP, but we found out that they were not having cerebral palsy based on the contemporary classification method. And another 25 children who have CP were not diagnosed as having CP, and we have also changed the subtype of 20 children. And most of the patients in our clinic used to come only to refill the medications ordered for seizure or any other behavioral abnormality that these children have. And patients were being appointed in an irregular pattern with no clear target set. So what we did, what the solution was, establishing a developmental clinic. So I started the first developmental clinic in May 2019, along with the advice from my advisors. And the clinic runs once per week, and we see about 15 to 20 patients in this clinic, children with disabilities. So the major thing that we changed on the care of these children is we integrated the WHO ICF model into our routine practice. So now we are giving focus to the activities, participation, the personal and environmental factors that affect the life of these children. So in our clinic, we have been practicing proper evaluation, counseling, and setting a clear target of intervention under, of course, the feasible setup that we have. And to date, we have seen 920 patients, and we have been able to explore available rehabilitation centers in the city which give focused care to such children, and we have been linking the patients to these rehabilitation centers. So now, how did COVID impacted our care? So the first case of COVID was reported on March 13, 2019 in Ethiopia. So this is my son, actually. So my son was born, COVID was reported in our country 2 weeks after the birth of my son. So that's why I put his picture here. So I usually relate it with the birth of my son. So immediately after the first case was reported, lockdown was initiated in our country and patients stopped visiting the clinics. So what we did was we started to call the patients using the available phone numbers on the charts, and actually the number of patients who really get the care decreased by more than 50%, because most of the phone numbers registered on the patient's chart doesn't work. And another challenge that we faced was the rehabilitation centers got closed. So these were the main outlets for these children and the parents. So now those children who had been showing some improvement in these centers, they were obliged to stay at home. And still, as I said on the initial part of my presentation, still there are many children in the different clinics in our hospital which are not incorporated to the developmental clinic. But because of COVID, since we cannot do proper evaluation which requires physical examination, we have not yet incorporated these children to our clinic. So how are we coping with this situation? So what we did was, the first coping mechanism was we started the teleclinic. So we are using the available phone numbers and those phone numbers that we have found while doing the research. So most of the parents, they actually communicate with me because they have my personal contact. So what we are doing is we are communicating caregivers on modified home intervention using simple objectives. So we tell the parents how to help their child using homemade objectives, like using cartoons, chairs, tables, woods, how they can use that to do home physical activities. And we have been able to link some of the parents to virtual channels, which were created as a parent support group on Telegram and other virtual channels. And I have been able to see those children who are actually admitted in different rehabilitation centers. And so one coping mechanism was going to where these children, like the orphans with disability, are residing in, and I have been giving clinical support there. And of course, the other thing that COVID impacted was the training and teaching service, which we used to give to our medical students. So we have changed that to a virtual teaching process. And last but not least, we have the past few weeks, we have been working with the Ministry of Health in integrating the developmental monitoring into the primary care level. So the piloting of this process has been completed the past few weeks, and now we are planning to integrate this early childhood developmental monitoring so primary healthcare workers can pick developmental abnormalities at earlier stage. So that will be integrated to the integrated management of childhood illness job aids in a few time. So we know this is temporary, so our plan for the future is to have a trained developmental and behavioral pediatrician, so and to establish well-organized developmental center in our hospital, establish an organized multidisciplinary team, and make the care for these children optimal, and of course the teaching system will go on. And since this is a new field to our setup, we are going to develop a new curriculum and of course expand it to the other regions as well. So with COVID-19, as you see, your life could have a lot of overlapped activities, and it could look like this maze. But what's the greatest coping mechanism I would advise is to take a break and think what you want to do. So thank you. This was my presentation. Over to you, Liz.
Thank you very much, Dr. Salamenesh. So I'm going to share Liz's slides. Go ahead, Liz.
I'm sorry about that. The introduction has been done. My name is Liz Khaemba. I'm a clinical psychologist working with children in Nairobi, Kenya. And well, just a brief what has been happening amongst frontline healthcare workers. That's who we have supported. When COVID first started, we wondered what to do as an association of clinical psychologists, but also just as healthcare pros within the country. And we actually came up really quickly and formed an alliance among associations that deal with healthcare. This included Kenya Medical Association, Clinical Psychologists Association, of which I'm chair, Psychiatric Association, Clinical Officers Association of Kenya, and others. And we tried to bring together all the people who act in the medical sphere to decide what we can be able to do to support our colleague care workers who are working in the front line. Next slide. So our collaboration started in April 2020. That was just about 3 weeks after our first reported COVID case. And we actually came up with the idea as a collaboration to start offering webinars to support, psychoeducate, and even provide some sort of intervention for healthcare workers in the country. So we spread the word as widely as we could at the time. And we started first webinars, which were led by the clinical psychologists, the first few. We talked about anxiety in the space of COVID among healthcare workers. We addressed children's mental health amidst COVID. Then we went on and had several other webinars dealing with topics like substance use. We had one on children with neurodevelopmental disabilities and how to provide for them support, especially those who are outside school and were having difficulties adjusting, and several other issues were discussed during those webinars. We since have had very many webinars, we have one webinar every Tuesday, which is today, between 7 and 8:30, with this collaboration. So we again thought of what other issues could help our colleagues with, and we of course had to create a lot of awareness about that these webinars were available, so other people, especially those in the rural areas, were able to access. One other thing that we did was the healthcare workers were available on psychological first aid, just to assist themselves and their colleagues. We started group debrief sessions, which we involved 50-year mates and taught them and how to do basic debrief. And this was also rolled out within the country as widely as we could do it at the time. So the debrief sessions were held with within the county hospitals, were done face to face, of course, with all measures taken into place, and or most of them were actually held online by us, supervised by us as clinical psychologists, and offered by the 5th-year medical students. And some of our more important roles, well, as clinical psychologists or as a clinical psychologist, was to be able to assess and provide therapeutic interventions. But this proved difficult because not many healthcare workers were actually willing to come online and access these offerings that we were giving. So as a collaboration again with Kenya Medical Association and the other associations, we decided to open a call center and call this the Healthcare Workers Call Center. And we again sent the message as far as we could that there was a call center which healthcare workers experiencing stress could actually call upon. And this was easier. So we found that many healthcare workers were able to call in. Many healthcare workers were able to find somebody to talk to. And what we did is we actually interviewed and sourced medical psychologists and clinical psychologists and clinical officer mental health professionals, nursing mental health professionals, and those are the staff we actually put in the call center. So our call center currently runs with 4 mental health nurses, 2 medical psychologists, and 2 mental health clinical officers, and a clinical psychologist on call, who when a matter needs to be escalated or when an issue needs to be escalated, these issues are escalated too. We also have a psychiatrist who is on call, always available in case we need to deal with more serious issues. So what has been happening at the call center is we have a toll-free line. So healthcare workers from all over the country are able to access this service, and we have received, since we started the call center in June, we have received quite a number of calls. We have received some cases that were fairly serious. We received most of our cases were around anxiety, around stigma, around stress and burnout. A lot of healthcare workers had started developing mood difficulties. There was some gender-based violence that had started also happening or was continuing during this period. Many healthcare workers we found reported being very lonely, as they could not talk to anybody outside the healthcare sphere. So the call center provided for them an opportunity to just talk to somebody, whenever they needed, as often as they needed, and really without any restrictions on time. So we tried to make the call center available for the healthcare worker as possible, as much as and whenever they needed it. We also managed to train the call center providers, the people who man the call center, on psychological first aid, and we worked also on this together with the Red Cross. We have continuous PFA trainings for them. We taught them counseling, customer care, on assessing clients, because from a psychological perspective, it's really difficult to assess without the benefit of the face-to-face. We taught them how to help when clients just needed to talk or needed to debrief, or just to offload and distress, and also to capture some data so that we have an idea what we're doing and how to handle this kind of situation if it ever occurs again in the future. As I've mentioned, a lot of the cases were kind of expected cases. We've had to admit several healthcare workers to hospital for specialized care, people who called in through the call center, and we are proud to say we may actually have helped save a life or two. As with any new project, of course, we had our challenges. Main challenge actually was first and foremost finances, because the associations were not able to support webinars that we hold every week. We still hold them to date. And also the costs around running the call center. So we managed to get a little funding to tide us through for now, but that was a really big challenge. We also had challenges with reach, where we were, because of lack of funding, we were actually also unable to reach our healthcare workers who work in the counties, in the villages, in the village small dispensaries and the smaller county hospitals. This has also now been solved once we got that funding, and, as we are now able to market or advertise our services more, considering this is a free service. We are now at least trying to create awareness using print, social media, and other kinds of media. So that is very positive. Our future plans post-COVID, we found that this call center has really been beneficial to healthcare workers, considering healthcare workers are the people who rarely reach out for some reason. We are expected to be strong. We are expected to kind of have it together. And so a lot of people actually, a lot of healthcare workers find it difficult when seeking help, but with the kind of confidentiality that we offer and the fact that the call center is actually run by the same healthcare workers who understand the difficulties of, say, a doctor, a nurse, an occupational therapist, or somebody else who works in the hospital. It's easier to speak to a colleague who actually understands the situation. So we are hoping we can continue providing this service even after COVID, where healthcare workers are able to reach somebody when and if they need for their mental health. Thank you very much. Back to you, Susan.
Thank you, Liz, for your good presentation. And now we'll hand over to Edith. I'm just going to share her screen. Edith.
Hello, good evening. Can you hear me, Dr. Hamidi? Hello? Hello, Dr. Hamidi, can you hear me?
You can hear
Sorry,
you.
Technical issues. Yes, we can hear you. Please go ahead.
Okay. My name is Edith Kagendo. As it has been said, I'm an occupational therapist working at the Aga Khan University Hospital. I work with a group of speech therapists, I work with the physiotherapists, we work with orthopedic technicians, and we could not all be there, so I'll represent some of them a little bit. So on the impact of the children with cerebral palsy and other, I would also include other deformities or other disabilities. Immediately COVID-19 was declared, most of the people just flew even before it was declared, like people have got to stay away from places. And some of the children had a lot of problems because they were taken up country, places where there is no internet, places where there is no connection, sometimes of even phones. And some of them, we could not reach them at all. Those that we could reach, next slide. Next. So those that we could reach, maybe on phone or something else, we were able to continue with them therapy. But unfortunately, we have those that were impacted by things like discontinued therapy, where you could not reach them at all. You could not trace them through any relatives, because wherever they were taken, maybe there isn't much of phone or activity going on. So then we also had patients who had been maybe assessed, they required to come into therapy, but they could not start therapy because they have gone away to places where maybe you cannot reach them, or you send them to nearest areas where they can receive therapy. So we also had patients who were already on therapy, and due to discontinuation, they had complications, things like they were doing joint range of motion, which would be lost if they are not doing any kind of therapy. Children who are using stitching aids, and maybe they left them in town or in their homes and went to their maybe urban homes, to rural homes, where they could not be able to continue enjoying such services. So we realized that some of them started regressing. Maybe by the time we are getting them, they've started regressing. So we also had lost chance to change a story of life, where maybe a child was doing very well, but because of that delay, by the time they get to meet you, or you get to reach them for you to do any kind of intervention, then they would maybe get so complicated, you're not able to get them. And some of them, they decided just to stay wherever they are. So, and some of them got to a turning point where they never used to get any kind of therapy, because maybe their mothers, their parents are working, and they never get any kind of, they don't get any kind of attention. Nobody will take them to therapy because their mothers are very busy looking for money to make a living. So when they went up country, maybe they got this person who cares, who can take them to a therapy place, and they can be done for some exercises. And so there are those that went and they benefited from this as well. So this is what we say is a blessing in disguise. So those places that they went to, maybe some people would be taught torso therapy, and they would intervene. They would do some exercises for them. And so these children had some good impact and not bad impact. So among the group of therapists, the kind of coping mechanisms that we had, we would start calling patients, reach them wherever they are. We would also, those that patients were able to come to the hospital, we would give them elaborate home exercise programs, so that in case they go away, they decide to get out of touch, then at least they know what to do when they get wherever they get. And we would also send those who could be able to use any kind of media. We could send them short video clips with activity demos. So like if you want to position a child to gain sitting, we would show them how to position them in different places, and they would be able to use them. We also tried emails, we tried text, WhatsApp, and it would work. We also used teletherapy for those patients who would be able, for the elite patients who would be able to use teletherapy. And we also used any locally available resources, where we would advise clients to use anything for assistive aids. We would use anything like a branch of tree. We would advise them to use maybe a branch of tree at home, to maybe put a rope, and they can swing maybe for vestibular stimulation. And we would use like the corner of the seat for them to be able maybe to sit a child, and maybe even stand in a drum of water for us to gain standing. So we also would train the caregivers through phone, through the media communications, and they would be able to help us through. It could be the parent, it could be maybe the caretaker, or whoever it is that we would get. We would also do return demos. When we train the caretakers, we would tell them to show us what they understood, for them to demonstrate what they have understood and how the activity goes. That at least we can be able to know whether from the other end, if they understood, are they going to do the right thing? Because then there are precautions of getting things like fractures or making things worse than they are. Next. So from the parents, we would get feedback that some clients would improve that kind of bridge therapy. We also get what doctors would get same cases that would not maybe come to us, but maybe go to their doctor. And they would also tell us that the clients are improving. And we also get parents and stakeholders who maybe just give a call back to appreciate the role that is played by the therapist. And for some parents, they would give an experience of a very new, a very new life with their children after maybe a long time without having any impact on their children. But now because they're staying with them at home, they would be able to interact with them. So my experience was, I would say it was really big. It was, for me, it was like 50-50. You would be able to reach the patients. Some of them you will not reach them. Sometimes they come and you also feel you have that fear because you feel like you are overexposing yourself. But then here is a patient that you have to help. Sometimes you would get clients coming, and when the clients come in after that, you see them and you find them queuing for the COVID test, and it would be a bit demoralizing. But on the other side, because we want to help you to carry on, soldier on, wear your PPEs, which were readily available, and do what you're supposed to do. And it was really helpful, I would say. The caretakers and parents were also feeling like the therapist is seeing everyone. And so they would feel like we are the ones who are battling COVID-19. So they would come and maybe stay very far away from you, give you the child and stay very far away from you. And sometimes you had to bridge the gap between you, the child, and the caretaker or the parent. You reassure the parent, talk to them, and also teach them how to practice the guidelines that are set. So they've got to wear their mask properly. You start from the ABCD of COVID, how to protect themselves, how to use the PPEs, and the experience would be great after that. So from the experience, when we had the respiratory therapist, our physiotherapists are doing that, it was also a gruesome experience. Sometimes they would get into the room and they would change into everything. Yet they are still patients. Initial days, they would almost come back when they are depressed. But after that, after they feel they're causing change in this patient, they would come back, feeling good, like I've made a change in life. Imagine that patient who has got a very bad chest, and after some time you feel it is getting better. It was really good. And for now, I would say most of the therapists, they feel like they're heroes. Not celebrated, but sometimes we celebrate ourselves, just for us to feel good. Yeah. And even other cases that would maybe come in and you have maybe had contact with a patient, and after that the patient turns positive, you would still soldier on, because the motive here is to help change lives and not to just duck off. It was a big experience. We still plan to continue doing it to the best of our knowledge. The next one is thank you. That is all I had for today.
Thank you very much, Edith. So thank you so much to the three speakers. It was excellent presentations. And now, like we'd mentioned before, we want to make this interactive, and we'll start with the questions that are in the chat box. So we'll start with, sorry, 1 second. Or someone can raise their hands as we're waiting for the chat, as I'm trying to access the chat box. All right, so I have the first question as we're waiting. So this is from Kito Yeke. Her question to everyone and even to the speakers is, how did the caregivers respond to the modified home interventions? And were they keen to the virtual support groups that were provided? We can start with Dr. Selamanesh.
Okay. Well, this is a new thing. As I was telling you, even the developmental clinic is a new thing in our setup. And now COVID has made things worse because we were even previously also we were having difficulties in sustaining the follow-up of these children. So actually the caregivers, they are happy that we are following them with the teleclinic. They felt that the doctors are caring for the children, and we are doing what we can. However, it's very difficult to follow whether those interventions are bringing improvement in the life of the child, because there are some parents who do apply what we advise them, but the other parents, they really need a physical push. So they really need us to talk to them in person than through this virtual meetings. So it has worked for some of the caregivers, but for the majority, it is like it's working in a way that we are adjusting. For those children who are taking medications, we are adjusting the medications, and we are telling them where to get those medications. And we keep asking how the child is doing, but that is not as effective as it used to be while it was in-person interaction.
Thank you, Dr. Selamanesh. Dr. Yeke, you have a question for the other speakers? And go ahead.
Hi, Susan. Yeah, so I mean, I just have many questions about, one, the experience of the caregivers, the experience of the healthcare workers, and we've got a lot of information from the three presenters, but also how did they deal with supply chain issues, stockouts, especially being in our resource limited settings where we're largely dependent on imports and those kinds of situations. So how did that impact the manner in which rehab services were being delivered as far as orthotics or, assistive devices and the like? And then Edith already highlighted on the bit about patients sometimes traveling up country. So then when there were difficulties with them returning into where they're officially registered to receive services, were they able to liaise with other teams elsewhere? And what was the reach? Were the community-based programs then picking up, or was the impact harder at the community level and perhaps needing access at larger centers and in bigger cities? What was the general experience? And that applies to all the presenters.
Okay, when the children traveled to upcountry, some of them would not even make any arrangements because they just traveled, and there wasn't like moving from one place to another. So they were not able to go back maybe to the county centers where they're able to claim their dues or where they would get any kind of help from. So they would just basically survive with what maybe relatives would be able to offer. If we would be able to get in touch with the therapists in a county where they are, then we would talk to them, and then they can be able to reach them maybe through phone, through the chief, and then they're able to help them that way. In some cases, you lose them and you have lost them like for real until they come back by themselves, because maybe there's no way you're reaching them, no phone network. And if there is phone network, maybe in that particular place, they have to go to several places for them to get maybe someone on phone. Yeah.
Thank you, Edith. And we're now interested in finding out from our participants from Uganda. And this question is from Robert Kabuye, who had asked a question about how comfortable were the caretakers doing home exercises. And so Robert, can you share your experiences in Uganda and how, in terms of home therapy or anything else that you had during the presentation? Sorry to pick on you, Robert. It's the name I recognize. That's Ugandan.
The other person who's here from Uganda is Sumwer. If maybe she's happy to let us know what their experience was.
Hi, this is Sumwer from Uganda. And actually, I am not the best person to speak because I'm in the country as a volunteer. And so the places that I volunteer when they shut down, so let me explain, when Uganda went into lockdown, we weren't even allowed to drive our cars. We just had to walk, and no place that I volunteer is in walking distance from where I live. And so you had to go through government officials to have a pass to travel in your car. And so I'm here under a Christian NGO, and many of the places I was working furloughed their paid employees. So it didn't really, it didn't seem appropriate for me to be taking their slots versus them being able to work and get money. And so I was actually off of work for 2-3 months. And the hospital where I worked the most, actually, because it doesn't have an emergency department or acute care, it also shut down for about a month or 6 weeks. And then they returned back, and when everything seemed to be going well, then I returned. I am also, through my church, I'm involved in a hospital ministry, and there have been some COVID cases at that hospital, so we have not resumed visiting patients there because we're completely unable to social distance, as you all understand what that's like for us here.
Thanks,
thank you. Thank you, Sue. And I actually have a question for Liz. And thank you so much for the support that you're giving healthcare workers, and even anyone else from other countries. I just want to know, in terms of the call center post-COVID, what the plans are for making this continue, because I think it's very important in especially dealing with stress and burnout for healthcare workers.
Well, post-COVID, we hope to actually continue using the call center. We hope we can. We've had equity funders, and we also had the COVID, the government COVID group also support us. So we are hoping that post-COVID actually get a donor who can help to just keep the call center running, because as I said, we have healthcare workers have real health issues, just like anybody else, and sometimes even a little more because of the kind of job that we do. And it is necessary that we have somewhere that we feel we can go, and somebody that we feel understands our unique needs. And this call center is really working well for that. Thank you.
Thank you, Liz.
Susan.
Thank you, Liz. And Kate, over to you. You have some questions for the speakers or the audience?
Hello, yes, I did have some questions. And I was worried about demonstrating videos or just how the parents ought to do the exercises. And Edith had already touched on that, about concerns about possibly causing fractures if parents were too vigorous with certain motions and movements. So how comfortable did parents feel? You know, I'm sure they were empowered, they felt quite empowered, but what was their comfort level when it came to administering the home exercises for themselves? And then the other thing I wanted to find out, and I think Robert has echoed it as well, about the respiratory therapists. What was their experience? Were they anxious? Were they concerned? Did we find dropouts with that? How did that impact the care given to special needs children? I think anyone can tackle it.
So I can start by tackling it. About the videos and short clips to show how parents can be able to do the therapy. Some of them were comfortable. Remember, we are doing return demos. After everything you show them, you do a return demo. So you're able to judge whether they can do it the right way. And you feel like they're not doing it the right way, then you stop them, then you start all over again until you feel you're comfortable. And they're also comfortable. Some parents were not comfortable at all. And some parents would even decline and say, no, I can't do this. Then maybe you try with another member of the family. If you make through, well and good. If it's not possible, then maybe you arrange with them if they can maybe get a letter and they're able to come to the therapy clinics. Remember, people were allowed to pass for the Kenya part, people were allowed to pass through the counties if you're given a letter from the doctor, or if you have an urgent need, an urgent medical need, and you had a letter from the doctor. And about the respiratory therapists, for those who are really in need, they would get maybe someone going to their home, but to don PPEs in case it's very serious. But for those that are just not confirmed infected patients and they're just at home, then the therapist would just use minimal PPE and conduct chest physio on them. It wasn't very comfortable, but you protect yourself to the best of your knowledge. And because we also have inpatient services, it was the same, both for the COVID patients and the other patients. Yeah.
Thank you.
Thank you. We have 4 more minutes, so I'll hand over to Dr. Samia, who is the chair of the Eastern African Academy of Childhood Disability. Go ahead, Pauline.
Right. Thank you, Susan, for running a very nice session. And I'd also like to thank Selaminesh, Edith, and Elizabeth for accepting to speak at this session as well. And it's actually interesting to sort of understand that, there are services that can support healthcare workers, because I don't think that that was common knowledge for everyone in Kenya. The other thing that was wonderful to see today was many people joining in whom we haven't seen at previous meetings. So thank you very much for making time to join us. I think that for anybody who has not attended our sessions before at AACD and would like to join in, would like to participate, they can either reach out to Suzanne, myself, Liz, Sur. If you recognize anybody from your country and you feel that you may not be able to reach one of us here in Nairobi, then feel free to speak to somebody else who is on the call from your country. and they can direct to us to join in, and so that we can involve you in future sessions. So apart from that, I think to also thank Jenny and Alicia, she's not here, for organizing us. This was a real marathon. Joyce, welcome. Nice to see you. I haven't seen you at sessions before. Welcome. And to everybody else, Rena, someone called Lake, Heather, I think is from South Africa, I may be wrong. Angela is also new, Osei. Angela Migo, our very own, is also on this session. And everybody else, including Robert, thank you very much for attending this session. I think that's all we had for today, and we're very happy to be part of this global initiative, and we really look forward to doing this again next year. Maybe COVID came with certain things that are blessings in disguise, despite all the stress that there has been. Thank you.
Thank you.
Nice seeing you, Sue, after so long.
Thank you.
Okay. So Jenny, we can close the meeting so that the next group can now use the link.
Lovely. Thank you very much.